Today on iConnect, I'm delighted to be joined by Professor Mandeep Sagoo, one of the leading ocular oncologists and a clinician recognized internationally for his work in the diagnosis, treatment, and research of rare cancers. Professor Sagoo has dedicated his career to improving outcomes for patients with ocular melanoma and has been at the forefront of advances in tumour genetics, prognostication, and eye cancer care. Through his work, he has helped countless patients navigate diagnosis, treatment, and the uncertainty that can come with a rare cancer. In this episode, we'll be exploring how ocular melanoma is diagnosed, how treatment decisions are made, what tumour genetics can tell us, and where research may take us in the future. Mandeep, thank you so much for joining me on iConnect.
It's a pleasure. Thank you for having me.
So you and I have known each other, believe it or not, it's 9 years this year. So it's a very long time. And I was a terrified young woman thrown into your company. And you had the job of telling me that I had ocular melanoma. You then went on to fit ruthenium plaque brachytherapy. And I'm very pleased to say that you did a really good job of killing my tumour. So first of all, thank you. But what on earth drew you into ocular oncology what did you study?
Well, firstly, it's always a pleasure and a privilege, actually, a privilege more than anything, looking after patients. So you've shared your story, but equally, people who are listening to this, but other patients, their stories are very powerful as well. And so what drew me to ocular oncology? Well, ophthalmology first. So I think that was at school. And so I was about 13 when I had that biology practical where you get, to study the eye. And in our school, they also gave us, I think, probably a cow's eye or a pig's eye to dissect and label all the parts and how it all worked. And I was fascinated by it. I thought, I'd love to, do something connected with eyes. So then I went off to medical school, did a PhD in electrophysiology of the retina, as it happens. And that set me on a track of doing ophthalmology. And within ophthalmology, I happened to see a patient in my first few months as a resident, as a junior doctor. And it turned out that this patient had an ocular melanoma. That was the first one I'd ever seen outside of a textbook. And so I referred the patient to the consultant in London, who was Mr. Hungerford. And a couple of weeks later, I got a letter back explaining what it was and what he was going to do. And that just fascinated me, just drew me in. And so since then, for more than 25 years, that's pretty much been my focus. And I think the thing about ocular oncology is it's very different to the rest of ophthalmology. So the rest of ophthalmology is much more about vision preservation or curing blindness, which are very important. But with ocular oncology, there is that aspect of the systemic side of things, of saving lives through eye treatment. So I think all of that drew me into doing ocular oncology.
Yeah, well, that's wonderful. And obviously you've gone from Mr. to Doctor to Professor. So you've accelerated up in your field, and it's an absolute pleasure to have you with us today. I do love a bit of background. I can't imagine you sitting there dissecting some poor cow's eye on a desk. It's oh no, really not my thing. I would imagine the whole field has changed so much since you started. So how long have you actually treated ocular melanoma?
So I was a fellow in about 2004. I did fellowship in retina at Moorfields, and part of that was oncology with Mr. Hungerford. And then I went to Wills Eye Hospital, 2005 to 6, where I trained with Dr. Carol Shields and the late Dr. Jerry Shields, passed away recently. And so I spent a year there learning how melanoma and other eye tumors are treated in the US. And then I came back and did more retina at Moorfields. And then in 2008, I was appointed to the staff at Moorfields, but initially went off to Sheffield the Ocular Oncology clinic there with Professor Ian Rennie and Mr. Paul Rundle. So I was seconded there for a year just to see how another centre in the UK does things. So that I'd worked in Philadelphia, worked in London, and then went off to Sheffield to see how they did things before I took on the Ocular Oncology clinic at Moorfields in 2009.
And your main treatment in Moorfields is plaque and enucleation, isn't it?
I mean, we do a lot of plaques. And so we see just under about 300 melanomas a year, uveal melanomas. We see ocular surface tumors as well. So, conjunctival melanoma and other conjunctival tumors. And so in the uveal melanomas, about half our patients are treated with a plaque. About a quarter we do proton beam, and then a quarter, unfortunately, the tumor is beyond radiotherapy, and we are having to do enucleation up front.
Okay. And can we do proton beam down in London, or are they all sent up to Clatterbridge?
They all go to Clatterbridge. So the machine for doing eye protons is in Clatterbridge, but all 4 centres in the UK prepare the patients, putting the tantalum marker clips on, and then sending all the data that is needed to the Clatterbridge team, who are absolutely excellent and do a world-class service. And then the patients then go there first for a planning appointment, and usually a week or so afterwards, their appointment is 4 days of radiotherapy.
And those people who have their eyes out, the enucleation, is there research done from those eyes that are removed? Do you look into those tumours and try and decipher where it's come from, what it is?
Yeah, no, exactly. I think there's 2 aspects to that. One is standard clinical care. So we need to know that the melanoma is all contained. Do they need any other treatment? So we need the pathology. We do the genetic testing on those samples. And then any excess tissue can be used for research. There are specific ethical procedures we have to follow to be able to do that. So we have to get the approvals to do that in historical cases. But prospectively, if there's any prospective studies that we're doing, then we have to seek permission from individual patients to use their tissue. And most people say yes whenever we've asked, because everybody wants to do the best they can to help others in that situation. So, we don't usually get any problems with that.
No, given the fact that it is so incredibly rare. So has treatment changed vastly, Mandeep, from when you started? Is there anything new in first-line treatment to the eye tumour?
Sure. So, I mean, treatments have been refined over the years. Plaque radiotherapy is actually very old. The first ever version of localized radiotherapy for the eye, so the predecessor of plaque brachytherapy, was done in London at Moorfields and Barts in 1929. And since then, so we're nearly 100 years old with that treatment.
Yeah.
And so since then, we have refined the techniques and, made it safer, made it better. The original surgeons, my predecessor, his name was Foster Moore, and he did very difficult operation where, plaques that are metal devices weren't available. They weren't invented. What he did was take a radon seed and implant it inside a tumor in the eye. And in those days, there were no microscopes to do that. So the skill of the surgeon was amazing. And they did that. He did that in adults with melanoma and also babies with retinoblastoma. So hugely technically difficult operations. And then Stallard, who was the next ocular oncologist at Moorfields, he then refined that technique. He embedded the radon seeds into a wax mold and put that on the outside of the eye, and brachytherapy was born. And then then they did cobalt plaques, which were used for many, many years. And then now things have evolved. In the US, they do iodine, and in Europe, mostly we do ruthenium. And these plaques are now manufactured, whereas in the old days it was a physics department who had to make up the seeds. So it's refined and changed and made safer over the years. And then proton beam came along, and that's another way of giving radiotherapy to the eye. In our service, the indication is pretty much if it's difficult to do the plaque, or we think the plaque is not going to work, then, due to the location of the tumor, for example, or the size of the tumor, then we go on to proton beam. And so, that's also saved many eyes as well. But I think we are on the cusp of big change in ocular oncology, just as other cancers have changed. Breast cancer and cutaneous melanoma all have biologic treatments. And so lately I've been spending a bit of time working on that. And I think I have genuine optimism that the way we treat things now will not be the way all patients are treated in the next 5 to 10 years. I think things are about to change for our subject.
Meaning that those of us new, or some people newly diagnosed in the future, might not actually have to undergo radiation?
Possibly. There's some interesting things coming out. There are trials that are happening. So there is a virus drug particle conjugate that's laser activated, which is for small melanomas. So it's a company in Boston, and I've been working with them lately, just learning about biotechnology and how we can apply that to eye tumors. And it's a company called Aura Biosciences. They have invented this, and the phase 3 clinical trial has just finished actually recruiting. So that's a global trial. And the idea is it's for small early melanomas. So it doesn't apply to medium or large size melanomas. And the idea is that this virus attaches cancer cells, and it's got a part of it, a drug conjugate, which you activate with a laser to activate the molecule. So you inject that in the outer layers of the eye, the virus drug particle. It binds to the cancer cells in the melanoma, and then 4 hours later, you laser the tumor. And you have to do 2 injections. You have to do 2 lasers all on the same day. So it takes the whole day to do. And in the earlier studies, the phase 2 study, which is a smaller study looking at what doses you need, they showed that with their higher dose, that they could achieve tumor control in about 80% of patients, but in 90% of patients, the vision was preserved. So those small melanomas where, we have to do radiotherapy and they're close to the foveal, the optic nerve, and it means that the vision's likely to go down, this may be a good alternative. So we need the results. We need the phase 3 is completed. It's over 100 patients throughout the world. Those results will be analyzed. And then there needs to be long-term follow-up. So yes, there's excitement now, but we need to see what it does in, 15 months, 3 years, 5 years. And that will give us a good idea. And hopefully we'll be able to offer something like that. But on the other end of the spectrum, so in medium and large size melanomas, there's also some interesting experimental things going on. So there is a protein kinase C inhibitor, a drug, which has been studied by a company called IDEA Biosciences. They're in California. And the idea is, so the melanomas are initiated by GNAQ, GNA11 mutations, and there are further mutations that occur. And this is a drug against protein kinase C. That's one of the pathways activated in uveal melanoma. And so this actually came out of Australia initially. What they found was there was a patient who had advanced uveal melanoma with liver disease that was really at an incurable stage. And they had this new drug, and with ethical approval, they offered it to the patient. And not only did the liver metastasis get better, But also they found that the tumor in the eye shrank. They hadn't treated the tumor in the eye. They were going to enucleate. And the tumor in the eye shrank. So this then led to researching it as a neoadjuvant that, in other words, if a patient is destined for enucleation, can you give the drug and shrink the tumor so that you don't need to remove the eye anymore? And the
Okay.
early indications are that that is possible in, about half the patients at least that they've studied so far. And then if you're going to have radiotherapy, can you shrink the melanoma, give them less radiotherapy, and then have a better chance of preserving vision? So these are ongoing studies. These are kind of, we're still 5 or 10 years off this kind of work, but this is the new stuff that's going on, which is very exciting that these biological pathways can be now targeted in uveal melanoma. And these studies are being set up now around the world to answer these questions. So I think, I'm very excited about being able to bring new treatments to patients in the UK as well.
I've got so many questions, but I will move on. I just want to fire stuff at you. So for someone kind of hearing the words for the first time, you've got ocular melanoma. I
Yes.
mean, what actually is ocular melanoma, uveal melanoma?
So ocular melanoma is a kind of fairly broad term of melanoma inside the eye. The tissue that it occurs in is the uveal tract, which comprises the choroid, the ciliary body, and the iris. So it can occur in any of those parts. And so it is a melanoma of the inside of the eye. And most people haven't heard of it at the time they're diagnosed. Everybody knows about skin melanoma. It's so common and the incidence has been increasing, and there are public awareness campaigns of covering up your skin and wearing sunscreen and all that kind of stuff. But a lot of people don't realize that you can get melanoma in the eye or on the surface of the eye even, but in uveal melanoma inside the eye.
But it's not brought on by sun. We know this, don't
No.
we?
No, yeah. So I think there's no strong evidence to say that it's UV related, whereas skin
Okay.
melanoma is definitely UV related.
And is there anything that predisposes you to end up with this? Is there a genetic flaw or pathway at
Yes.
all?
So, in the majority of patients, no. I think it's sporadic, but there are some patients who have an underlying predisposition syndrome, the BAP1 mutation. So they can get other rare cancers, and uveal melanoma is one of those. And then there are patients who have excess pigment in the eye, excess melanocytes, so nevus of Ota, it's called, that predisposes you. There's another condition called neurofibromatosis that also predisposes you to a slightly increased risk of uveal melanoma. And then the traditional teaching always is people who are from Northern Europe with kind of pale skin, blue eyed, blonde haired is the traditional teaching. But actually, actually, you see it across the board. It's more common in Northern Europeans of that description, but we do also see it less commonly in Southern Europeans, Mediterranean, and also less commonly in Middle Eastern and then Indian subcontinent, Chinese, and it's extremely rare in Africans. But London being a mixed population, we have occasionally seen it in Africans as well.
I know, it's mad, isn't it? It's,
Mm.
the predisposition. And it used to be something that was detected around the age of 50-ish. But I think
Mm.
that is purely down to the fact that your eyesight starts to go a little bit squiffy. So if you haven't been to the optician on a regular basis, you'd probably venture in, and that's when it's detected. But these days, with kind of technology within opticians developing and the OCT scans that are offered, you must be seeing younger patients, which is very sad, but actually really good because it means
Yeah.
that it's caught early.
Yeah. So I think the age distribution has always classically been middle-aged and elderly, but occasionally you will see it at extremes. The youngest I've ever treated was a 1-year-old with a uveal melanoma. And so it does occur at the extremes of age sometimes. We do occasionally see teenagers and very young adults with melanoma. So it does occur in outside the kind of standard demographic. But you're right, we are seeing cases earlier, and that's thanks to people going to optometrists, getting OCTs and fundus photographs done, and picking things up. And then the optometrists are sending patients in. There's a lot more awareness and knowledge about it now. And many of those are just nevi, and there are guidelines of for optometrists of what to send in and what not to send in. Because nevi in the eye are very common. Up to 10% of the population has a nevus in their eye.
Mhm.
So if all the eye clinics in the UK had to check all the nevi in the country, that's all they would do. They wouldn't be able to treat, glaucoma and cataracts and diabetic retinopathy and all those other potentially blinding conditions. So it's not practical to see every nevus patient in the clinic, but in the hospital clinic. But as people go to optometrists and get these tests done, some of those patients will need to be referred in for either things that need an opinion from a retina specialist or an ocular oncologist, or that they've picked up melanoma that hasn't caused any symptoms at all.
And what are the kind of standard symptoms for ocular melanoma? Is there a kind of data set of this is what you'll
Yeah.
experience?
So in about three-quarters of patients, there'll be some kind of visual symptom. So blurred vision, flashing lights, sometimes floaters can be part of that, but they're very non-specific. So those symptoms occur in diabetes and other things as well. So they're non-specific symptoms. So any kind of visual symptoms should be checked. Don't ignore that. Go to the optometrist first. If they're worried, they'll send you on to a hospital eye clinic. So any type of visual symptoms, but the quarter of patients who get no symptoms at all, the only way you can detect that is by going to the optometrist regularly and getting the eyes checked thoroughly.
Is there a guideline? Should it be every year, every 2 years? What I mean,
So
in your
mostly,
experience?
yeah, mostly if there's no lesion present, then every couple of years is what optometrists will do. But if they discover a nevus in the eye, they might do an annual check, which I think would be very reasonable.
Okay. And do they look for something in particular? Is there a big difference that can be seen between a nevus or a nevi and an ocular melanoma? And to follow on from that, I suppose my question is, can one turn into the other?
So the melanomas that they pick up, they will send. They won't monitor those. So anything that's suspicious enough, large enough, have orange pigment, or it definitely is growing on serial photographs, so there's a high suspicion it's a melanoma, they will send that. And yes, nevi, I think, do turn into melanomas. It's rare. I think the published quoted risk is about 1 in 8,845 from big studies that were done in the US. So the risk is low, but it's not zero. And that's why, even with the very bland nevi that might make it to the hospital, when I discharge patients back to the optometrist, I always say that it should be checked, every so often, every year to 18 months, if it's a completely bland looking nevus.
Yeah.
So an optometrist can do that with serial photographs. Obviously, there is some cost element often in that you have to pay for a photograph when you go to the optician, but it's a good way of monitoring these things or just keeping a check on them.
Yeah, absolutely. And back to kind of surgery and the information that you get from the tumours that you treat. Is biopsy a thing? Is that something that is done? I'm not talking about the eyes that are enucleated, but say
Yeah.
kind of proton beam or plaque.
Yes. Yeah. Yeah.
Okay.
So I think yes is the answer. Biopsies are done, and they're done more often now than they used to be. So even in the last 5 to 10 years, things have changed a bit. It's not for diagnosis normally. Big studies have shown that actually just from the tests that we do in the clinic, we're 99% accurate. Or in other words, in 99 out of 100 cases, we don't need a biopsy to make the diagnosis of an eye melanoma. But so in the 1 out of 100 case where the signs are equivocal, then we might do a biopsy to make the diagnosis. But the role of biopsy really is for prognostic information. So there are a number of factors in prognostic information, the size of the melanoma, where it is in the eye, which part of the uveal tract is affected, whether there's any melanoma outside the eye. And then you look at the cell factors, what cell type is it? And then beyond that, you can look at genetic testing, and that has a correlation. So changes in particularly chromosome 3. So if you have a loss of chromosome 3 in the cells, in the melanoma cells, then that does make it a higher risk melanoma. So the biopsies are mainly done in uveal melanoma for prognosis rather than diagnosis.
And is there a risk with this? I mean, I know if you stick a pin in a breast tumor, for example, it might seed itself into the lymph, and they like taking things out in entirety. How does it work in the eye?
So I think the risks are low, but there are risks. So the risk is the tumors could sometimes bleed when you take a sample. There's a risk that you might not get enough tissue to get a result. So you go to all this trouble, you send it off to the lab, and they say, well, there aren't enough cells for us to make a call. So that does happen. And occasionally you can get retinal effects. So occasionally a detached retina can occur. Again, low risk. The risk of seeding, I think, is low. It's not zero, and I've seen it happen, but it's a low risk. So we always talk to patients, and if they want it, then we will do it. There's degrees of it. So if it's a 1 millimeter tumor, then it's going to be difficult for anybody to get a sample out of that. But if it's a reasonable size and location, and the patient wants it, then I think it can be done.
And the benefits, Mandeep, from doing this are what? What are you going to gain as a patient from knowing what your
Yeah.
tumor's makeup is?
So at the moment, I think this is the difficulty, that you could do all of this, get a result, and the results aren't 100%. So if you're higher risk, it doesn't always mean that you're definitely going to get metastasis. You are higher risk of metastasis, but that doesn't mean 100% risk. It doesn't alter your treatment. So in other cancers where you get prognostic information, you can then give adjuvant treatment to reduce some of those risks. So the systemic risks. And so we haven't got to that yet. And some of these drugs that I've been talking about, maybe the darovasertib, the oral drug, or other drugs that are coming, they may help in that situation. Tebentafusp has been tried as well. And so there may be emerging treatments that do change that. But also, I think in the future, there may be ways that we can get that information without being so invasive. So
Okay.
in other cancers, you can measure circulating tumor DNA. So tumors release a particular DNA sequence or signal, and that can be picked up. The problem is in uveal melanoma, in primary uveal melanoma, the signal's not strong enough. We can't measure it at the moment. In metastatic disease, it's different. But in disease that's localized to the eye, currently it's just not possible to measure it. But there may be other ways. There might be that we can take fluid from the aqueous, for example, or from the vitreous, which is less invasive than going into the tumor, and find a particular molecular or protein sequence that tells you that. And there are colleagues who are working on that. And that has been done in retinoblastoma to great effect, because that is a tumor which is very aggressively, seeds if you go into it. And so doing a biopsy out of retinoblastoma is an absolute no. And groups in Birmingham and in Los Angeles have developed an aqueous sampling technique where they can pick up retinoblastoma DNA. So I think things will evolve in the way that we do the tests.
Okay. And do we know why it primarily goes to the liver? What's the biological reason behind that?
Yeah. So, I mean, the answer is not fully. So
Okay. Oh, it was just
there
a
appears
question.
there appears to be a mechanism that makes the cells more hepatotropic. That meaning favoring the liver, but the complete mechanism of that has not been worked out as far as I know.
It's funny, isn't it? It's just because a lot of cancers are kind of within the lymph system, and you hear of people having lymph
Hmm,
nodes removed and all the rest of it. And this one just chooses very, very blood-fed organs within the
correct.
body.
Yeah.
So after you've had your treatment, we've come to see you, one of your colleagues, one of the other amazing surgeons around the world. What happens? Do you see us regularly? Do these things ever regrow? I know mine's dead. You told me only last month. So how is follow-on treated, and also kind of what happens to the patient after they come away from this treatment of their primary source, their primary
Yeah.
cancer?
So I think the follow up is mainly around the response of the tumor to treatment. So in my practice, we tend to see patients in the first year every 4 months or so, sometimes every 6 months, but mainly 4 monthly in the first year, then down to every 6 months in the second year, and then beyond that, once a year. And what we're looking for is regression of the melanoma. In the first year, it's often that it's not growing anymore because melanoma in the eye grows slowly and it shrinks slowly after radiation. It doesn't just disappear. And so we're checking carefully, doing ultrasound scans, doing photographs and OCT scans just to make sure that the tumor's responding. The risk of regrowth, once we know that it has responded, is actually quite low. In proton beam, is probably around 5% or less. In plaques, it's a bit less. It's about 10% or less. So
Okay.
there's not a high chance that it's going to regrow, but there is a small chance, and therefore we keep an occasional check. And certainly in the Moorfields practice now, we're sharing care with local hospitals a lot more. So we used to follow up everybody at Moorfields all the time, no matter if they were 1 year out from radiotherapy or 10 years out from radiotherapy, they'd still come to Moorfields. But the pandemic stimulated a lot of kind of shared care, which is, I think, quite right. I think once you don't need the specialist care, then I think being back close to home is better with access to the specialist center whenever you need it. So, for example, patients who've been referred back to, Bristol or Southampton or Oxford or other centers, if there's ever any doubt, often the consultant there will just send photographs to us and scans, and we can review those in our MDT meeting and we can do a plan for local care. We will do that. But if the patient needs to come back to London for any reason, then we will bring them back. So it's not discharge in the traditional sense that you never have a door back. The door is always open, and the shared care model, I think, works very well.
Yeah, I mean, I know it saves a lot of traveling and those
Mm,
4-hour waits. I mean, you've got an
absolutely.
appointment at Moorfields. You know you're gonna be sat on that chair for 4 hours.
It is a long wait.
It
And so
it
that's one
used
of the
to.
things that, exactly, that's one of the things that we've implemented since the pandemic that seems to work very well.
Yeah, I know it's been greatly received as well. So, no,
Good.
it's good. So we're released from your care and we're popped out back out into the community, and obviously we've all been on Doctor Google, and this thing might end up in our liver. Who's gonna look at that? Do we go to our GP?
So it does vary a little bit around the country, but a lot of the Moorfields treated patients, we have a network of medical oncologists who are interested in uveal melanoma. And so we will refer patients to local medical oncologists that we deal with for surveillance. So it tends to be a liver scan every 6 months for the first 5 years, and then for the next 5 years annually. And so we ask our medical oncology colleagues to take care of that side.
Is that because the risk of it spreading, if you've kind of made it to 5 years, is less the kind of further away from primary treatment you get?
Correct. That's right.
Okay.
There are a few cases where there might be late relapse, but the majority are going to occur in the first few years.
And how do people live with this diagnosis?
Hmm.
Um, it can cause, I mean, apart from the point that people can lose their eye, so they
Yeah.
have a very kind of visual, actual physical
Yeah. Yeah,
change to them. It does
absolutely.
change you, a
It does
diagnosis
change
like
you.
this.
It does change you,
Mm.
definitely. It's, losing the eye. No eye surgeon wants to do that. That is something that we all want to avoid, but it's in some patients, it's unavoidable to save their life, really. So that's one way of looking at it, that it is a huge, huge thing to undertake for patients to lose their eye. But the benefit is hopefully to save their life. Um, but I mean, the impression that I have got doing this for more than 20 years is it's humbling to see the courage and the bravery of patients. And that is really what spurs you on to keep going, keep researching, keep looking for new ideas. We did some work on 3D printed prosthetics because I felt that that whole process of rehabilitating patients could be improved. So we did a trial at Moorfields. We published how the technique fitted the world's first fully 3D printed prosthetic eye, which looked great. But that's research, and we're trying to translate that into the NHS. So there are hurdles to do that, but I'm sure we will get there. So that kind of seriousness of the condition does spur you on to try and advance the subject. There's loss of vision, obviously, but there's a visible difference when you have lost your eye. And the prosthetics, handmade prosthetics are really, really good. It takes hours of patient work to make them. And even if the prosthetic looks great, it moves great, people still feel that difference. So I'm very conscious of that. And then loss of vision as well in radiation treated eyes. It affects their day to day living in many ways. Some people will have some double vision. So I think managing those expectations is important, because if you know what could happen, then you're a little bit more prepared. But the reduction of vision, it has implications for people's jobs, for their social life, and so on. And that's why it's important to keep looking at new possibilities, the new kind of drugs that might, or new treatments that might help preserve vision.
Yes, speaking from experience,
Mm.
I underwent surgery after my plaque. It's a long time ago, but I'm sure you remember you had to cut the muscles to get the plaque in because my tumor was in
Mm.
a really awkward place. And yes, I
Yeah,
did end up with double vision, and then
double.
there is the loss of
Mhm.
vision. And actually, it does affect so much, even being able to go for a walk. I mean, it was yesterday. Paul said
Mm.
to me, "What are you doing?" I was like, the step wasn't where I was
Mm.
expecting it, because your
Yeah.
depth perception goes, and it just kind of
Yes,
throws everything. A
it does.
question I've never asked you:
Mm.
what happens if you leave a tumor in situ? I mean,
Mm.
it's obviously not something as an ocular oncologist you would do, but
Yeah. Yeah. Yeah.
what would happen?
Yeah. So if you left a tumor in situ, it would slowly grow. We know that tumors do grow, and then it can start affecting local tissues. So it can grow through into the iris. It can cause glaucoma. The pressure can become very, very high, and patients can become quite sick with it. That they're vomiting and so on because the pressure has gone extremely high in the eye. And then grow outside the eye into the socket, which requires a huge operation where not only the eye but the whole tissues of the socket need to be removed. And then the bigger they are, the higher chance there is of them spreading to the liver. So leaving them alone for a very long period of time can do that. That's a different situation to where there's a possibility it's an early melanoma. There's scans and so on that we do are a little bit equivocal. And then the advice from the consultant or from the MDT meeting after the images are reviewed might be, let's watch this. And if it grows, we'll treat it. In that situation, you're not putting yourself at any excess risk. That used to be standard when I started. If you had a small melanoma, because there was a, a chance of vision loss, the standard practice was to watch small melanomas carefully, and if they grew, then treat them. Whereas now the pendulum's the other way, where we're treating as soon as we can. But sometimes there's a doubt that could this just be a nevus that's a little bit leaky or suspicious looking. And then if you wait for growth, but are being monitored, then that is safe. And that's
Okay.
not just my impression. That's been shown in studies that if you do that careful monitoring and then treat, it doesn't pose any excess risk to metastatic involvement.
I'm not sure I'd cope with that.
Yeah,
But I,
so
I see where you're going.
yeah, it depends how certain you are on your 99 out of 100. You can be certain, but if
Yeah.
there's that 1 out of 100 where it's too small to biopsy, to do a diagnostic biopsy, and it's a little bit suspicious, but not quite everything that you'd expect in a melanoma, then maybe sensible to watch it carefully over 4 months, see if it changes, and then treat.
Okay, so it's roughly 3 or 4 months you'd leave a watch and wait type
Yes,
approach.
yeah,
Okay.
yeah.
And I suppose if it doesn't grow, then are you pretty sure it's just a puffy nevi? I mean, you can get like warty moles, can't you? So can
Hmm.
you get a warty mole on the eye?
Well, not quite warty, but you can get big nevi. Yeah.
Okay.
So I've seen those where just by size, they would be big enough for a melanoma size, but actually they're not leaking fluid. They're not, haven't got orange pigment. They don't grow. So yes, you can get large nevi or giant nevi, as they're sometimes called. And you can get moles that aren't turning malignant, but they're bleeding and leaking. So similar mechanism to macular degeneration when aging change causes leakiness or a blood vessel to grow in wet macular degeneration. You can get that kind of process over an aging mole. It's not always that there's fluid means it must be turning malignant. There are other reasons for it as well.
And when you kind of take something to MDT, is there a
Hmm.
bunch of you and you've got the images and the
Mm.
measurements and everything
Yep.
like that? Would AI ever come into play in that kind of situation where you were, is it, isn't it?
Yes. So even before that, I think AI will come into importance. So we are working on a project using photographs that you have taken just as part of a routine check, or we do photographs at Moorfields on a wide-angle camera. Many opticians have that. The local hospitals have that, and our project is telling apart a nevus from a melanoma using AI on a photograph of the eye.
Okay.
And we're not the only ones doing that. There are other groups who are also doing that. Our model so far is about 95% accurate.
Wow.
And so it's good, but it needs a lot of work. So I've got a research fellow and a postdoc fellow working on that project. We're working with one of my colleagues at Moorfields, Professor Piers Keane, who is an authority on AI in the eye. So we're collaborating with his group and developing this model. We'll need to test it, validate it. So there's many steps to get there. But I think that will be the biggest thing is, if you can go into an optometrist, have your annual photograph taken, and if the AI algorithm says, this is okay, just watch it, or if it says, this is not okay, send into the hospital. It doesn't diagnose that it's a melanoma, but it tells you that this is suspicious enough that it needs to be seen by a specialist. I think that will make a huge difference. And wouldn't it be great if we could get patients in at an earlier stage where we can treat possibly with these new emerging treatments and preserve vision and
Yeah.
save their
And
lives?
and equally not actually jam up the system
Yes. Yeah.
with
Yeah. Yeah.
unnecessary appointments. I mean,
Absolutely.
everybody needs to be concerned about things, but at the
Sure.
end of the day, a freckle might just be a freckle.
Freckle.
So, yeah.
Yeah, and not only that, it's the anxiety. You get a referral to ocular oncology, even if it's a freckle, and you've read that word oncology. It patients quite rightly become very anxious. So yes, it could improve the whole pathway if we manage to implement something like this.
And is it something that's being done like nationally or internationally? Is this going to be a thing, or are you doing it as one center and then other people are coming up with
So
different models?
We do have a collaboration with the US on what we're doing, but there are several groups working on it. And that's good because each is testing their model in their population. So the model may work differently in Northern Europe compared to Southern Europe, compared to US or UK, in London particularly, where we have that mixed population. So having multiple groups work on this is actually a good thing.
Okay, that's wonderful. I mean, things are progressing in healthcare, full stop. I mean, not just in the world of oncology and uveal melanoma. What have your patients taught you throughout this time? Is there anything that's stuck with you in particular, Mandeep? Someone who's really made a difference to your life, career, thought process?
Every single patient teaches you something. There is not a patient where I do not learn something from. And that doesn't mean that it's, an unusual presentation and you've learned, okay, that, melanoma might present in this way. Yes, there are those, but, it's humbling and a privilege to do the job that I do. And sometimes you marvel at the way the patients and their families are dealing with this. Sometimes it's their inner fortitude or the way they look at things and so on. So I would say there is not a single patient where I do not learn something, which then spurs me to think, well, maybe I can do this or maybe I can do that to improve the lives of patients.
Well, you have improved many a life of many a person.
Oh, well,
And
thank you.
I thank you very much for joining us today on iConnect.
It's been a real pleasure. And also thank you to you and to Ocumel UK for raising the profile and supporting patients because, we're one part of it in the hospital, but out there they have to face it in their day-to-day lives. So I'm really pleased with what you guys are all doing as well and very happy to take part. So thank you for the invitation.
Thank you very much. Bye-bye.
Bye.
If you or someone you know has been affected by the topics discussed in this episode, support and information are available. You can visit Ocular Melanoma UK at www.omuk.org for guidance, resources to connect with our helpline, and others who understand. Remember, no one should face ocular melanoma alone.